everyone just calls me Ayo. I'm a third-year med student at Tulane down in New Orleans, Louisiana. And I'll be presenting today complications following hook plate fixation of the AC joint systematic review. So the AC joint is pretty much a really susceptible area to injury just because of the location of where it's at. You can get injury just from, a patient falling or just blunt force trauma. But with that, a common way to fix that would be the hook plate and screw design. It's a pretty common, useful way to kind of fix that joint again, simply because of the fact that not only does it give it a strong fixation of the joint, but it also gives the patient early rotational mobility of the shoulder. Even with that, you do have positives, which I just stated, but then you also have some negatives when it comes to using the hook plate and screw design. One of the major drawbacks of using this is the fact that you have to have two procedures done when using it. You have to have a procedure to place the hook plate in and a procedure to take it out as well. With that, physicians generally check between or have follow-ups between 3 to 6 months, just to go ahead and get that hook plate taken out. And some other complications I'll be talking about later within this presentation. So the purpose of this study was just for us to use different articles and different reviews just to be able to find out which were the most common complications of using the AC joint. We think that it's a very good method of AC joint fixation, but we also wanted to allow physicians to know what type of complications they should be looking for and when they should be looking for it. As far as the methods, we looked at studies identified from January of 2020 and forward. We used databases like PubMed, Embase, Cochrane, Library, and Web of Science. We used a combination of terms like acromioclavicular joints, coracoacromial ligament, coracoacromial arch, just different combinations of these search terms. As far as inclusion criteria, we looked for peer-reviewed publications that were reported in English from the year 2000 and moving forward, but we generally try to focus in from the year 2020. As far as exclusion criteria, we didn't want to use any articles that were non-peer reviewed. As you can see here, we have the Rockwood classifications. These are the different classifications of AC joint separation. As far as type 1 and 2, those are pretty much dealt with conservatively. We don't have to do any surgical treatments. As far as type 3, that's up to the physician pretty much deciding on whether or not they want to do a procedure. And that's pretty much based on the horizontal stability of the joint at that moment. What we do want to focus on is, what we want to focus on are types 4, 5, and 6, because these are the ones that we actually do surgical procedures on, the ones that we'll use the hook plate on as well. As far as results, we have looked and found that we have three complications that are the most common when it comes to using the AC joint, the hook plate. You have subacromial osteolysis, we have infection, and we have loss of reduction. The plate part of the hook plate sits on top of the clavicle, whereas the hook goes underneath the acromion. And because of the way the prosthesis sits on the joint, it just moves all the time, especially if you have a patient that likes to actually move their body or they're more active, it tends to rub against the bottom of the acromion and cause subacromial osteolysis. With that being said, it can also lead from there to loss of reduction just because of the softening of the bone as the prosthesis is rubbing against the acromion. And sometimes you just have loss of reduction when you have a patient that's more active than your average patient. So as far as conclusion, as I said before, we found that the most common complications are subacromial osteolysis, loss of reduction, and infection. And what we found out was that if you want to get the positives of having the hook plate, which are the strong fixation of the joint and also early rotational mobility of the shoulder without trying to avoid the negatives, you can kind of augment that with a different type of fixation, whether that be suspensory fixation or a ligament tape or wrap of some sort. And why is this important to us? It's because, number one, we want to be able to know what to look for when it comes to using such, I think a positive piece of equipment. We want to know what we want to look for, when to take out the prosthesis. And also we would like to also kind of just inform the patient, allowing them to know that their recovery will go a certain way And with that, you can increase patient satisfaction in the long run. Any questions?
In any of the studies, did they consider, I guess, PT compliance or follow-up in their rate of complication?
From what I remember, they do. The patients that generally go to PT generally do a lot better, especially because in PT, they also learn the do's and don'ts of using the shoulder. Whereas the ones that aren't pretty compliant, they try to just do whatever they can with the shoulder, not realizing that, you can't lift, a certain amount of weight, or you can't do certain things that you normally would. So the ones that comply generally have better outcomes with the hook plate. As far as revisions, from what I've seen in the articles, a lot of times they try to go ahead and replace the hook plate just because they like the outcomes and the positives of using that prosthesis. But a lot of times, because they generally do follow-ups between 3 and 6 months, sometimes they'll have to do a revision a lot earlier than that, which is something that they try to avoid. But there's no, there's no set in stone time for follow-up. So basically with this research, we're trying to see should we go with the 3 to 6 months, or should we start looking a little bit earlier?
Thank you.